Dr. Akanksha, Senior Lecturer in Periodontology Department at BBD University. Today's topic is role of other predisposing factors in the etiology of periodontal diseases. First we come to the anatomic factors that are proximal contact relation. The integrity and location of the proximal contacts prevent interproximal food impaction. Food impaction is the forceful wedging of food into the periodontium by occlusal forces. Now coming to the sequelae of food impaction. Feeling of pressure and the urge to dig the material from between the teeth, vague pain which radiates deep in the jaws, gingival inflammation with bleeding, varying degree of inflammatory involvement of the periodontal ligament with an associated elevation of the tooth in its socket, prematurity in functional contact and sensitivity to percussion, destruction of alveolar bone, gingival recession, periodontal abscess formation, and the caries of the tooth. Now coming to the cervical enamel projections and enamel pearl, they appear as narrow wedge-shaped extensions of enamel pointing from the CEJ towards the furcation area. Their clinical significance is that they are plaque retentive and can predispose to furcation involvement. Third is intermediate bifurcation ridge. It is a convex outgrowth of cementum that runs longitudinally between the mesial and distal roots of a mandibular molar. These ridges are found more frequently on first molars. These irregular contours make plaque and calculus removal more difficult, and inadequate plaque and calculus removal can lead to failure of periodontal ligament. Next is palato-gingival groove. It often begins at the cingulum and extends apically for a variable distance. Deep pocketing of maxillary incisors, spatially isolated, should prompt an examination for this plaque retentive root anomaly. If the palato-gingival groove is associated with bone loss and attachment loss, the clinician may attempt to remove the groove through odontoplasty or to reduce its depth to minimize plaque retention. Second is iatrogenic factors. Inadequate dental procedures that contribute to the deterioration of the periodontal tissues are referred to as iatrogenic factors. Restorative dentistry. The improper use of rubber dam clamps, matrix bands, and burrs can lacerate the gingiva, resulting in varying degree of mechanical trauma and inflammation. Besides this, restoration can do more harm than good to the patient's oral health if performed improperly. Like overhanging margins of restorations and crowns accumulate additional plaque by limiting the patient's access. Over-contoured crowns and restorations tend to accumulate plaque and possibly prevent the self-cleaning mechanisms of the adjacent cheek, lips, and tongue. Restorations that fail to re-establish adequate interproximal embrasure spaces are associated with papillary inflammation. Overhanging margins. Changing the ecological balance of the gingival sulcus to an area that favors the growth of disease-associated organism at the expense of the health-associated organism and inhibiting the patient access to remove accumulated plaque. Next is prosthesis. Gross iatrogenic irritants such as poorly designed clasps, prosthesis saddles, and pontings exert a direct traumatic influence upon periodontal tissues. Orthodontic procedures may affect the periodontium by brackets, favoring plaque retention by directly injuring the gingiva as a result of overextended bands, chemical irritation by exposed cement, and by creating excessive unfavorable forces or both. The extraction of impacted third molars often results in the creation of vertical bone defect distal to the second molars. Careless use of elevator or forceps during extraction results in crushing of alveolar bone. Malocclusion can also act as a contributing factor. Crowded or malaligned teeth can be more difficult to clean than properly aligned teeth. Now coming to the habits as contributing factors, the tooth surface, usually the root surface, can be abraded away by improper toothbrushing technique, especially with a hard toothbrush. The abrasives in toothpaste may contribute significantly to this process. Flossing and toothpicks can also cause damage to dental hard and soft tissues. Flossing clefts may be produced when floss is forcefully snapped through the contact point so that it cuts into the gingiva. Mouth breathing can dehydrate the gingival tissues and increase susceptibility to inflammation. These patients may or may not have increased levels of dental plaque. In some cases, enlargement may also occur. Tongue thrusting is often associated with an anterior open bite during swallowing. The tongue is thrust forward against the teeth instead of being placed against the palate. When the amount of pressure against the teeth is great, it can lead to tooth mobility and cause increased spacing of the anterior teeth. Smoking is one of the most significant risk factors currently available to predict the development and progression of periodontitis. Apart from these, factitious injuries like self-inflicted injuries can be difficult to diagnose because their presentation is often unusual. These injuries are produced in a variety of ways, including pricking the gingiva with a fingernail, with knives, hairpins, and by using toothpicks or other oral hygiene devices. Thank you.